Welcome to week 4. Today we are going to talk about something super practical, which is fructosis, or FO in short. You have probably seen this before, maybe in a clinic, maybe in a sports shoes, or even on someone you know. They may look very simple, but they can totally change how a person walk and feel. We will go through what is FO actually do, how we design them, and most importantly, how we decide which one to use for different kinds of the patient. Okay, so here's the game plan for today. By the end of this session, you should have a good idea of what is a fructosis, what fructosis is supposed to achieve biomechanically, and you will understand the basic of how we design and build one, the different type we use, and how to match the right one to the right clinical situation. And plus, we will talk about how they are made and what makes a well-made fructosis differentiate from the other, from the one that just okay. So what is fructosis really? Fructosis at its core, it is an external device that goes inside the shoes or support the bottom of the foot, but its job is way beyond than that. We use fructosis to support flat feet, overload painful areas, fix alignment problem, or even prevent serious complication like a foot ulcers in diabetics. In short, in the small device, the big job. And when designed properly, it can help someone walk more comfortably with better posture and way less pain. Okay, now let's talk goals. Okay, what are we trying to achieve with an FO, fructosis? Okay, first up, we want to redistribute pressure. Okay, you can imagine someone with too much pressure under the ball of their foot, like a diabetic patient. We want to take some of that load and spread it out more evenly. And then next is the alignment. If the foot is rolling too much, overpronating, or rolling out, we want to guide it back to healthier position. And third, motion control. Sometimes the foot moves too much or too little. Either way, we want to control that movement so it doesn't cause pain elsewhere. And finally, shock absorption and gait efficacy. The right fructosis can make a walking smoother, lighter, and more stable, and especially during push-off and also landing. Okay, now we will look at the design principle. Now, when we design a fructosis, we think about more than just the shape. We ask, does it fit the foot like a glove? Is it doing what it's supposed to biomechanically, like lifting the arc or stabilizing the heel? Is it comfortable enough for someone to actually wear every day? And will it survive real life walking on pavement, climbing the stair, running after bus? And we also think about how stiff or flexible it should be. For example, a marathon runner will need the same orthosis as elderly diabetic patient. Okay, you can imagine that. And based on this principle, we usually group fructosis into four main categories. The first one is functional, second one is accommodative, third one is sports, fourth one is pediatric. Okay, let's look at what makes each of these special. Okay, this table gives you the quick overview what each fructosis is used for. But don't worry, I'll break each of them down, so it actually makes sense later. Okay, we go to the next slide. Functional fructosis. Alright, first up, functional orthosis. These are the go-to for correcting how the foot moves. Okay, like say someone foot flattens too much when they walk. So these orthoses help to lift and guide it back into alignment. And it's usually made for firmer material like PP, polypropylene, and you will often see added features like medial wedge or deep heel cups to control the way the foot land or push off, right? You will they use this for things like flat feet, posterior tibial tendon issues, or even general overpronation. But here's a catch. Okay, it needs to be designed carefully. If you overcorrect, you might create new problem like knee pain. So assessment like foot scans and gait analysis are really important here before jumping into fabrication. Yeah. Now next we have accommodative orthosis. These are all about comfort and protection. We don't want to change how the foot moves. We just want to cushion it and prevent damage. So this is especially important in people with diabetes, severe arthritis, charcot foot. Okay, if you don't know what is charcot foot, you can Google. And their feet are at risk of also injury just from everyday pressure. So these orthoses are made from softer material like EVA or Plastazoid, and they are molded to follow the shape of the foot exactly. They go inside extra depth shoes and help spread out pressure. And if you ever seen someone with a rocker sole shoe and full contact insole, chances are they are using accommodative foot orthosis to stay mobile and injury free. Athletes. Okay, now let's talk about athletes, the people who push their feet to the limit. Okay, sport orthoses, they are designed to help with that. Okay, they offer support, they absorb shock, and they help prevent injuries like plantar fasciitis, shin splints, or Ashley's problem. Okay, these are usually lighter and a bit more flexible than functional orthoses, but still supportive. Okay, we might use impact absorbing materials in the top layers and stiffer material underneath for structure. And yes, the sport matters. Football boots needs different support than running shoes. So we always consider the type of footwear and activity when designing a foot orthosis. Yeah. So now we will look at the pediatric foot orthosis. Okay, pediatric orthoses are their own world. Kids are not just small adults; they are growing, developing, and changing all the time. Okay, so we need orthoses that support development, not just fix current problem. Okay, common conditions include flat foot, cerebral palsy related deformities, or things like metatarsus adductus. So these orthoses often have higher side wall for better control and are made from materials that balance flexibility and durability. And here's the most important thing: kids grow very fast, so we need to reassess these orthoses regularly to make sure they still fit and still support what we want them to support. Okay, now let's shift gears a little. How do we actually get foot orthosis into patients' hand or shoes? Okay, there are custom orthoses made specifically for one person, and prefabricated orthoses, which are made in bulk and come in standard size. Okay, so custom ones are the gold standard when the foot shape is unusual or the problem is a little bit more complex. You can get a better fit with more targeted support, but it takes time, of course, skill, and also a bit more expensive than the prefabricated orthoses. Okay, prefabs are quicker and cheaper. They are great for short-term use or for milder issues, and sometimes we even start with the prefabrication as trial to see if the patient responds well before ordering a custom foot orthosis. Okay, when we say custom foot orthosis, we mean something that is based on that patient actual anatomy, using a 3D scan, a foam impression, or even a plaster cast. So it is designed from scratch based on how the patient walks and where the pressure points are. Okay, these are great for diabetics, athletes, and kids with unique foot shape or complex gait issues. They take longer to make, but the fit is unmatched and the correction is more precise. Okay, so prefabricated foot orthoses are ready-made ones that you can pull off the shelf. They come in sizes like shoes, small, medium, large, and can be modified slightly, like adding a pad, okay, or trimming the arch. And they are handy when you need a quick solution, like for an acute heel pain or plantar fasciitis, but they are not ideal for very long-term use in complicated cases, because it fit and support more general. You can think of them like buying a clothes off the rack versus tailoring a suit. Yeah. So these are the mass-produced devices, often available in general sizes, like I mentioned just now, small, medium, or large. They are not made for specific foot, but rather to fit a range of foot shapes with common needs. So you might reach for prefab foot orthosis in cases where the biomechanical issues is mild, the patient needs immediate relief, or budget is a concern. So for instance, in public healthcare setting or for temporary use. So the big advantage here is how fast and accessible they are. Okay, patient could walk in today, get prefabricated foot orthosis, and live with some degree of support and improve the fit. But of course, there are limitations because they are not custom made. They won't provide any precise support needed in more complex cases, and they may wear out more quickly or become uncomfortable over time. Okay, let's now shift into the fabrication process. Okay, manufacturing or fabrication process, whether we are making a custom foot orthosis or modifying a prefabricated one. We always start with a thorough assessment, okay, that includes getting a clear picture of the patient's symptom, like a pain location, daily activities, footwear, habits, and any relevant medical history, like diabetes, arthritis, or if the patient has previous surgery. Then we go into the clinical assessment. This could include observing patient gait, checking foot posture, testing a range of motion, and assessing muscle strength. And technology is really helping us here. We now have a plantar pressure mapping system and 3D foot scanners that can give accurate data, although traditional foam boxes and plaster casting are still widely used in many clinics. Okay, the key here is collecting as much objective and subjective information as possible so that we design an foot orthosis that truly meets the patient need. Okay, so once we get our assessment, we move into the design phase. This is where we select the right foot orthosis based on the patient condition, functional or accommodative, okay, and define this thing like arch high, heel cup depth, whether a mat pad is needed, or if any medial or lateral posting should be included. If we are using digital process, we will bring the data into CAD software where we can modify the model virtually. If we are going to use manual route, a positive model is made from the cast and adjustments are done by hand. And this is where your knowledge of biomechanics really come into play. Okay, every contour, wedge, or cut in the device has a purpose, and that's why what turns a simple insole into true orthotic intervention. Okay, fabrication process. There are a few different fabrication technique for making foot orthosis. One of the most common technique is thermoforming, and this involves heating a plastic sheet and vacuum forming it over the mold. Another option is the lamination, which is involve layering material like carbon fiber for extra strength. And then 3D printing is also becoming more common now in advanced clinics, although allowing precision design that can include both rigid and flexible zone. And then whether you are working manually or digitally, you will be using materials like polypropylene PP for the base, EVA for the support and posting, and soft foam or leather for the top cover. And manual finishing includes shaping, trimming, and grinding, and it requires attention to detail to ensure that there are no edges or pressure points. Okay, the final step in fabrication are all about finishing and checking the orthosis before it reaches the patient. Okay, this includes trimming excess material, apply top covers, smoothing edges, and making sure everything fits snugly into the patient's shoes. Okay, we also do a fit and comfort check. We want to confirm that the device follows patient anatomy, redistribute pressure as planned, and feels comfortable enough for daily use. We test it both statically and during gait to see if it correct motion, offload pressure, or support the structure we are targeting. Okay, and of course we record everything, including serial number and material use, so we can make informed adjustment later. Okay, quality control, clinical use. Okay, let's talk about some common condition and how we use foot orthosis to manage them. Okay, first up is past planners, or we normally call it as flat feet. Okay, this patient often complain of the tired feet, arch pain, or even knee or lower back discomfort. Our orthotic goal here is to lift and arch, control over pronation, and provide overall foot stability. We usually use semi-rigid or rigid foot orthosis with the medial posting and a deep heel cup to keep the rear foot aligned. And you will often notice improvement not just in foot symptoms but in how they walk and stand throughout the day. Okay, next we have now the opposite, the pes cavus. This now is pes planus. This is a pes cavus, which is the opposite, or high arch feet. And this patient usually have a poor shock absorption, which means that they tend to develop metatarsal pain and calluses under the forefoot, and even ankle are unstable. Okay, in these cases, our orthotic design focuses on adding cushion, typically using soft material like EVA or Poron, and distributing pressure more evenly across the foot. Okay, we might add metatarsal pads and sometimes lateral posting if ankle is unstable. Okay, now we have the plantar fasciitis. Plantar fasciitis is one of the most common foot complaints. Patient often describe sharp heel pain first thing in the morning. Our goal here is to offload stress on the plantar fascia, especially where it insert at the heel. So we design a foot orthosis with a deep heel cup, a soft heel pad, and strong arch support to reduce tension on the fascia. Okay, these small design changes and significantly can reduce pain over time, especially when the paired with stretching and good footwear. Okay, we have now metatarsalgia. Okay, you can see from the picture. With metatarsalgia, a patient experience pain at the ball of the foot. You can see the red area there, usually due to the excess pressure on the metatarsal head. The orthosis should redistribute the pressure there in this area and provide more cushioning. And we typically use metatarsal pad or domes positioned just behind the metatarsal head, combined with a soft top cover to improve comfort. And in more advanced cases, we might recommend a shoe with a rocker bottom sole, okay, to reduce forefoot load during gait. Okay, now in the patient with the diabetic neuropathy, there is a high risk of injury because they cannot feel the pressure. Okay, for those who has diabetes, they cannot feel the pressure. Actually, they cannot. Sometimes they have no sensation in that area, friction or pain. They cannot feel that. That means also and can develop quickly and become very serious. So our job is offload that pressure, prevent shear forces, and provide a soft a stable platform for walking. We use multi-density foam, full contact design, and seamless top cover. Because this orthosis must be reviewed regularly or for wear and hygiene, and adjusted as needed to prevent complication. Okay, hallux valgus. Now, hallux valgus, one of the, or we call it as bunion, are common and often painful. Okay, these usually come with swelling. You can see in the picture. At the bunion area is located there, the red area you can see, are commonly very painful. They usually come with swelling, sensitivity over the first metatarsal, MTP joint, and in orthotic design we aim to reduce pressure on the bunion, stabilize the medial arch, and prevent further progression. And we might cut out space around the bunion in the foot orthosis, add arch support to reduce pronation, and recommend toe spacer or wider foot if it necessary. Okay, then we have one condition, posterior tibial tendon dysfunction. This condition involves degeneration of the tendon that support the arch, okay, often resulting in acquired flat foot. Okay, and the patient usually will report a medial ankle pain and collapsing arch. In early stages, we can use a custom foot orthosis with a strong medial arch support and medial posting. If the deformity is more severe, we may need to go beyond foot orthosis and prescribe an AFO, ankle foot orthosis, like UCBL design or more rigid AFO structure. Okay, and then the other common thing is the arthritis or osteoarthritis. For patient with arthritis, the main goal is, of course, comfort and joint protection. Okay, they often have a joint stiffness, limited motion, and pain during weight bearing. And orthosis in this case should cushion impact, support the foot structure, and sometimes include modification like a rocker sole to reduce pressure on the painful joint. And metatarsal are typically softer and more forgiving to accommodate joint changes and swelling. Okay. Now we still have one more, last one I think. Even a small difference in the leg length, or we call it limb length discrepancy, can throw off a patient's entire gait pattern. Okay, one shot is shorter than the other, and they might report back pain, hip discomfort, or knee strain. We often address this with a heel, sleeve, or platform orthosis to bring the shorter limb up to level. Okay, for discrepancies over 1 cm, we build gradually over time and make sure the leaf is firm and stable, and this small change can make big difference actually in the overall posture and also comfort. Okay, clinical design checklist. Okay, here, so whenever we are designing for orthosis, right, whether it is for an athlete, a diabetic patient, or someone with bunion, we always ask few questions. Okay, what function is currently impaired? Okay, you try to think what function is impaired now, and what structure is being overloaded or misaligned, and what modification like padding, wedging, or contouring can help to restore a better balance and movement pattern. Okay, you need to always ask this when you are designing for orthosis. Okay. Okay, alright, that brings us to the end of today's session on foot orthosis. I know we have covered a lot, from the type of foot orthosis to the design, fabrication, and the real world clinical application, but I hope that you're starting to see how much impact that even a small device like an foot orthosis can have on someone's daily life. Okay, whether it is helping a child to walk better, protecting a diabetic foot from injury, or supporting an athlete to keep doing what they love. And orthotic design is about understanding the person behind the condition. So next week, we will move further up to the limb, start looking at the ankle foot orthosis. AFO, so make sure you review your notes, and if you are working on your video presentation, start gathering your reference early. As always, if anything today felt unclear, if you want help connecting the theory or real practice, just drop me a message or ask me during the lab time. Okay, see you next week in the lab.